which is on epithelial disorders. We will be covering benign epithelial disorders, hyperplastic and malignant. So let's start with benign, hyperplastic and malignant are three types of epithelial disorders. Let's start with the benign epithelial disorders. Number one is squamous papilloma. Squamous papilloma is benign epithelial growth, which is the papillary growth of the oral mucosa. Its etiology is the human papillomavirus, HPV. You can see in this squamous papilloma, it shows as a papillary growth of the mucosa. Now we come to the clinical features. It is exophytic in nature and measures less than 1 centimeter in diameter. It is sessile or pedunculated, which means it may be connected with a stalk or may not have a stalk. If it is keratinized, it will be white in appearance, and if it is non-keratinized, it will be pink in appearance. It occurs as solitary lesions and not as clusters. Its main locations will be the soft palate, uvula, ventral and dorsal surfaces of the tongue, the gingiva and the buccal mucosa. What will its histopathology show us? If you look at the histopathology here, you will see that there is a layer of connective tissue inside. Then we have the parakeratin layer, if you see in this, the spinous layer, the basal layer, and then there are blood vessels. Histopathology will show thick papillary layer of keratinized or non-keratinized squamous epithelium. The normal maturation pattern of the epithelium will be intact. Central core of the fibrovascular CT will be of connective tissue, which will be fibrovascular. You can see there are vessels, and the papillary projections may be of two types, long and finger-like, or short, round and blunt. There will be a mild degree of basilar hyperplasia. The basilar layer will be hyperplastic to some degree, and heterogeneous group of papillary lesions will be found. There might be papillary lesions of different compositions. If you look at it in the book, these are the two diagrams which I showed you. If you have any questions, you are free to ask me in the comments below. Now let's move on to benign pigmented lesions, for which the first one is melanotic macules. Melanotic macules are small pigmented macules. Melanotic means that they consist of melanin pigment. They represent the foci of post-inflammatory pigmentation or true ephelites, which are called freckles. After the inflammation, pigmentation is occurring because of the melanin which is draining out in the layers after bursting of the dendritic cells which contain melanin. They are of two types, labial and oral. I will explain this to you with the help of, if there are dendritic cells present in the epithelial layers, the basal layers, they contain melanin, and after inflammation they burst. The pigment flows inside the cell, inside the layers between the cells. Thus, the foci of post-inflammatory pigmentation are represented by melanotic macules. The simple distribution will be there are labial or oral. If they are present on the skin, they will be called freckles. The clinical features are of the labial melanotic macules that they are asymptomatic, small, flat, brown, black in color. They are present on the vermilion border of the lower lip, usually. They are solitary, but sometimes they can be multiple. They measure less than 5 millimeters. They tend to occur near the midline of the lip. If this is the lip, tend to occur near the midline. Oral ones are very rare. They are less than 1 centimeters in diameter. They are present on the gingiva, the buccal mucosa, the soft palate, with rare solitary multiple dark brown black lesions from 5 to 2 mm can be seen on buccal mucosa and palate of 20 to 40 years old African American patients. So this is called oral melanoacanthomas, which are the proliferation of dendritic melanocytes, which I told you here. The proliferation of dendritic melanocytes in African American patients is called oral melanoacanthomas. Above the basal layer, these melanocytes they proliferate above the basal layers in area of focally thickened epithelium. So it will show marked acanthosis and mild parakeratosis. Develops with few months and resolves without treatment. So TX means treatment. What will the histopathology show us? An increase in melanin granules in the basal cell layer. The melanotic granules will increase because of the proliferation of dendritic melanocytes. The melanocytes confined to the basal cell lesion, you will find melanocytes in the basal cell layer. Occasionally clear cytoplasm, no nuclear atypia. The nucleus of these cells will be typical. Basilar region of epithelium and superficial connective tissue will have a mild infiltrate of lymphocytes and histiocytes because of the inflammation. Post-inflammation, this happens after inflammation, right? Small granular deposits of melanin will be found because, as I told you, of the melanocytes, some within the histiocytes and often visible in the superficial connective tissue. The dropout of melanin from the melanin containing epithelial cells into underlying connective tissue where it accumulates within the macrophages, it's called melanin incontinence. This is a term you need to learn. The dropout of melanin, like the melanin here, it's dropping out from the melanin containing epithelial cells into the connective tissue. It accumulates in the macrophages in the connective tissue. It is called melanin incontinence. As we have just read, I would like to show you what they look like and what the terms we have used mean. The labial melanotic macule of the lower lip, as you can see, is present near the midline of the lip. Over here you can see the oral melanotic macule, which is darkly pigmented on the maxillary alveolar ridge. And if you see the histopathology, you will get to know that these arrows, they show the deposition of melanin, which have come out of the granules. They have come out of the dendritic cells, the melanocytes, and they have deposited here in the basal cell layer. Okay, I also want to tell you what acanthosis and hyperkeratosis mean. If you can see here, hyperkeratosis means an excessive thickening of the stratum corneum. If it is in the orthokeratin, if orthokeratin is involved in the composition, it will be hyperorthokeratosis, and if parakeratin is involved, it will be hyperparakeratosis. Okay, and you'll read about it further, but since we have used these terms, I would like to elucidate on this. Acanthosis is benign hyperplasia of the squamous epithelium, which is an increase in the thickness of the spinous cell layer. Spinous cell layer increases in thickness. It's called acanthosis. The retipegs are also broadened and elongated. and the coloration of the vasculature is dimmed, so it appears as white in color. It has a lot of reasons. We will read about it in further. Now we've come to smoker's melanosis. So, what is the etiology of smoker's melanosis? It occurs due to cigarette and pipe smoking, and it is the pigmentation of the oral mucosa. If you can see here, this is the buccal mucosa of an older patient, and it will show you that it is, you can see the melanosis here, as he has smoked for many years. So, the constituents of tobacco smoke, what are the factors which cause it? Some constituents of tobacco smoke increase the melanin production. So, they can be a cause for smoker's melanosis. Also, some female hormones amplify the melanin pigmentation. They cause more melanin to be produced. Thus, if females are using contraceptive pills which provide female hormones, more intense pigmentation will be produced in female smokers, as two factors will be involved now, right? Effective modification. Clinical features. Maxillary and mandibular anterior labial gingiva will be the most involved. The buccal mucosa, the floor of the mouth, and the soft palate. Okay, if the soft palate is involved and you can see melanosis here, it is usually associated with emphysema or bronchogenic carcinoma, so it should be carefully monitored. Histopathology. What will the histopathology show? It will show melanin deposits increased in the basal epithelial cell layer cells, the basal cell layer, and also in the underlying connective tissue. There will be mild infiltrate of lymphocytes and histiocytes, as we saw in melanotic macules, and we will also see melanin incontinence. Melanin incontinence, I told you what it is. If you have forgotten it, go back and check. Dropout of melanin from melanin containing epithelial cells into the underlying connective tissue where it accumulates within macrophages. It's called melanin incontinence. So, okay, if you want to see the picture, here is the picture of smoker's melanosis, and here is the histopathology. Histopathology will show that melanin granules are phagocytized by the macrophages within the connective tissue, and the abundant granules in the basal cells, and this is similar to melanotic macules. The melanin deposits have increased. Now let's move on to nevi. Okay. What are nevi? These are also benign exophytic lesions. They are usually pigmented. They are also called moles. If they are present on the skin, they are called moles. So most of all, they are present on the skin and mucous membranes. So orally, they will be present on the hard palate and gingiva. They are of four types: intramucosal and intradermal. So intramucosal and intradermal are the same, but if they are present on the skin, they will be intradermal, and if they are present orally on the mucosa, they will be called intramucosal. Junctional, compound, and blue nevi. So let me show you here how they can be differentiated. The intramucosal will be present in the connective tissue. This is the epithelium, this is the connective tissue, so they will be present entirely in the connective tissue. Whereas in the compound ones, they will be present both on the connective tissue and on the epithelial boundary. Okay, and the junctional will be present only on the epithelial boundary, the junction of the epithelium and the connective tissue. And the blue nevi will be spindled and they will be in the connective tissue, but they will give a bluish appearance. Okay, we are on the clinical features. Asymptomatic pigmented brown, black, slightly elevated papules or flat macules on the hard palate and gingiva. They grow very slowly. And so asymptomatic because they are painless. You don't feel them. When you go for a regular routine checkup, the dentist will tell you that you have a nevus on the hard palate or gingiva. They grow very slowly and measure less than 1 centimeter in diameter. If they're present on the skin, they will have more hair than the surrounding skin, as you might have seen. So, jumping on to the blue nevus, as it is in our course, the clinical features will tell us that it is benign, pigmented, and it has a dark blue dome-shaped papule. or it may be flat also, like a macule on the skin or mucosa, or on the hard palate, same as nevus. So histopathology, what will it show? Pigment producing cells which are spindled, as I showed you, and fusiform, the shape. Dendritic cells rather than rounder or epithelioid. They won't be round, they will be spindled and fusiform. They will be confined to the connective tissue and separated and parallel to overlying epithelium. As you can see, I showed you, they are here, they are parallel and separated from the overlying connective tissue epithelium. Melanin containing macrophages are called melanophages. They will be present among the dendritic nevus cells. No tendency to undergo malignant transformation. They are not malignant, they are not pre-malignant, they are just present in the connective tissue parallel to the overlying epithelium. Okay, this is nevus of the palate, and this is intradermal nevus, as you've seen in people. These are the histopathology showing the nevus cells arranged in clusters here, here. This is the junctional nevus. Basal, they will be on the junction of the connective tissue here and the basal cell there, here, if you can see them. And this is compound nevus. It's also present in the connective tissue here and the epithelial outline. And this is the blue nevus, be bluish, located in the hard palate. It's the most common location, bluish. And this is the histopathology of the blue nevus. Melanin laden cells, and they're confined to the connective tissue only. This is the epithelium, this is the connective tissue. And over here you can see the high powered microscopy, elongated spindled cells, and they are parallel to the surface epithelium. They're placed like this. Okay. Now we will start with leukoplakia. What is leukoplakia? What does this mean? Leuko means white, plakia means a patch. So leukoplakia is a white patch or a mucosal lesion which cannot be scraped off or sloughed off. Like the Candida albicans, it forms a thrush, but it can be scraped off. The thrush can be scraped off, but leukoplakia cannot be scraped off. Thus we have this definition. So, what are the clinical features? The occurrence rate is 1.5% to 12% in a normal population, and 5.4% lesions will develop into squamous cell carcinoma. Thus, this will form a malignant condition later on. In smokers, this incidence will increase to 16%, the incidence of forming a squamous cell carcinoma. It will show as a flat, smooth, translucent macular area to thick, firm, rough-surfaced, fissured, raised plaques. If you look here, what can you see? A white patch on the buccal mucosa. It can have a different appearance in this one. This you can see is flaky, it's thick, it's rough, fissured, and it's raised. So, thus, it may be flat, smooth, and translucent, but if it increases further on, it will be thick, firm, rough-surfaced, fissured, and raised plaques. Secondly, buccal mucosa, the floor of the mouth, the labial commissures, like the corners of the mouth, the lateral borders of the tongue, the mandibular and maxillary alveolar ridges are the common sites. The use of smoked and smokeless tobacco, pre-malignant epithelial changes, Epstein-Barr virus in patients with HIV, as they have immunosuppression already. If they can come in contact with Epstein-Barr virus, they may be predisposed to leukoplakia. These are the etiologies. And chronic irritation to ill-fitting dentures. If ill-fitting dentures are still used, keep on being used, and they rupture and cause leukoplakia, the chronic candidiasis, chronic lichen planus, and genetic disorders might cause leukoplakia. What will the histopathology show? It will obviously show what causes the white color. Hyperortho or parakeratosis may cause the white color. Acanthosis might cause the white color. Stratified squamous epithelium is an avascular tissue. It is usually white. So in the underlying connective tissue, there are changes. The vasculature is hidden due to hyperkeratosis and acanthosis. It will show a white color. It will depart a white color. Hyperparakeratosis and acanthosis will also depart a white color. The vasculature will be decreased. There will be a decrease in vasculature and increase in the collagen content of the connective tissue. Thus, a fibrous scar formation will be formed, and thus it will not be erythematous. It will show as white. You understand, there are so many reasons for it to show as white patch. The diagnosis will be done as a biopsy. So there are two types of biopsy. If there is a small lesion and it is entirely removed, it is called excisional biopsy. And if there is a large lesion and it is partly removed, it is called incisional biopsy. So if you want to see it, this is leukoplakia. This is leukoplakia, the white patch. Now we'll move on to epithelial hyperplasia, the hyperplastic disorders. So first one will be hyperkeratosis. We have already talked about it, but this will be a bit in detail. Hyperkeratosis is the excessive thickening of the stratum corneum. Hyper and keratosis will be of two types, ortho and para. It can be non-keratinized also. Okay. Orthokeratin is non-nucleated, and parakeratin has a shrunken pycnotic residual nucleus. You understand? Orthokeratin will be having no nucleus, but parakeratin will have a shrunken small pycnotic nucleus, a residual nucleus. Okay. The keratin will function as a protective barrier on the normal skin and mucosa. If it increases, then the appearance will change. Okay. What will be the stimuli? Stimuli will be chronic frictional irritation. So what will it be caused by? Ill-fitting dentures, smoking, tobacco, placement of tobacco pouches, cigars, and chewing betel nut and other things like that. So there is a thing called smoker's keratosis, which is slightly elevated white striae found in smokers, chronic smokers. The uniform thickening of the keratin layer, there is present the uniform thickening. It's not ununiform or bumpy, it's uniform. The most common site is the labial mucosa, and the characteristic feature of the histopathology will be chevron or church spire organization of the parakeratin. I will show you that. Then we will find thin oral epithelium, which will be non-keratinized. Vulnerable. Let me tell you this. If the oral epithelium is thin and also non-keratinized, then it would be vulnerable to premalignancy because it is already thin. If it would be thick, it would be saved. But no, it is thin. It does not have a protective barrier as much as a thick epithelium would. And it is also non-keratinized. We just read that keratin functions as a protective barrier on the normal skin and mucosa. Thus, it is having both these, it is vulnerable to development of premalignancy. Now we'll find out about these types. So if you can see this, yes. Epithelial types are 4. Actually there are 3, but we will divide them into 4. So first one is orthokeratinized. Orthokeratinized is thick. Okay, it will be present on the hard palate, gingiva, alveolar mucosa, and dorsal tongue. These are the common sites. Parakeratinization will also be thick. It will be present on gingiva, alveolar mucosa, and dorsal tongue. The non-keratinized is divided into thick and thin. The thick one will be present on buccal mucosa and the vestibule, the labial mucosa and the vestibule. The non-keratinized thin epithelium will be found on the floor of the mouth, the ventral tongue, the lateral tongue, the soft palate, and the gingival sulcus. So these places are vulnerable to premalignancy the most. Here you see these. Do you see this pattern? It is greatly thickened without nucleus. This is hyperorthoparakeratosis. It is an uneven surface. which is, I have told you, this is chevron shaped or church spire shaped. Okay. And this is hyperparakeratosis. You will see the residual nuclei. If you can see the residual nuclei, and the pycnotic, they are called pycnotic and shrunken. The parakeratin is church spire or chevron shaped. It will be more visible in here. If you look, you can see the shape here. Let's move on to acanthosis. Acanthosis is the excessive thickening of spinous cell layer of the squamous epithelium. It results in two things: the broadening and the elongation of the retipegs. The retipegs are the connection between the epithelium and the connective tissue, so they are broadened and elongated because of the thickening of the spinous cell layer. It is called a benign hyperplasia. It obscures the coloration of the underlying blood vessels and appears as leukoplakia. So, as I told you, if acanthosis occurs, if hyperkeratosis occurs, the underlying blood vessels are erythematous, but they are dimmed. The color is dimmed and it appears as white as leukoplakia. If you look at this is acanthosis. The stratovite squamous epithelium is hyperplastic. It has increased in its thickness, and the retipegs have elongated and broadened. If you look here, okay. Why is it formed? It develops in response to chronic irritants, as we have read: ill-fitting dentures, smoking, chewing of betel nut, and such things causes retipegs to assume an irregular and exaggerated downward growth pattern that resembles squamous cell carcinoma. So, if it resembles squamous cell carcinoma, it is called PEH, pseudoepitheliomatous hyperplasia, because it resembles the carcinoma. Look here. The epithelium is acanthotic and the retipegs are elongated and in an irregular pattern. This falsely resembles squamous cell carcinoma. Thus, it is called pseudoepitheliomatous hyperplasia.